Hope you all can see me. Great, thank you so much, Maria. Okay, I'll start with the session. Before we, start our session, let me disable the chat because I have a lot of questions to ask. Great. Okay, I want this session really to be interactive. So you can unmute your mic to answer or question, or even you can post questions and answers in the chat box. I'll keep the chat box open. Is it okay? Is it clear? Are you guys with me? Thank you, Muhammad. Thank you, Maria. Thank you, Malik. And I request everyone to be really, really active. Okay. Acha. Before I start the session, I have a question for you all. Okay. I'll give you one scenario. A 2-year-old child. Okay. There is a 2-year-old child. Parents took her to the doctor. Parents says whenever camera flash shows, camera flash is shown, it shows white in one eye. Okay, they haven't tested the kid's vision so far till since birth. Till
Recording
that
in progress.
Okay, till that moment, they haven't, visited any optometrist or ophthalmologist. That is the first visit of the child. Okay, in the first visit, doctor says, in camera flash, it shows white in one eye, white in color in one eye. I'll post the options in the chat box. Please look at the options and tell me what we should do further for that case. Do you want to observe and review? Do you want to refer the child urgently? Or you will be unsure of the diagnosis? What would be your answer? You can put the option in the chat itself, A, B, or C. There is no correct or wrong. Okay, everything is a learning opportunity. So don't get jittery. This is not your exam, so don't get that exam pressure. Feel free to answer. Okay. Can you all look at the options that I have put in the chat box? Yes. Or if you want to unmute and answer also, it's fine. No problem. Whichever option you feel like, you can. Okay, great. Someone has answered. Oh, my video is not visible. It is visible, I guess. Guys, can you see me? See my face? Am I visible? Host, can you? Yeah, please. Yes, sir. Okay, great. I'm visible. Yes, I'm visible, Mr. Vasan. Okay. Can you answer the question? Can you all just one option? Do you want to say observe and review? Option A. Refer urgently. Option B. Not sure, unsure of the diagnosis or further step. Which one? Chat is disabled. Okay. Why the chat is disabled, guys? Host, can you help me to enable the chat? Okay. So people are saying that chat is disabled. One second. Yeah. Just sorry, guys. Give us a minute. Great. Thank you so much. Enabled. Great. Thank you so much. Wow. B, option B. Amisha, Madhu, uh, Tahir Mohammed. Wow. Kankshi. Great. Sundara Vadivel. Gautam. Option B. Great. Yeah, that's the correct answer. Option B. We have to refer the child immediately and urgently to the ophthalmologist. Okay, that is the right answer. Great. I have another question for you. A 3-year-old child, again, okay, a 3-year-old child comes with intermittent squint. Okay, there is no pain, and but the fundus view, when you do the fundoscopy or fundus using fundus camera or even ophthalmoscopy, the fundus is very difficult to view. Okay, some obstruction is there. Fundus is very difficult to view. What would you do? Would you dilate, refer, or wait? Again, I'll post it in the chat box. What would you do? A 3-year-old child comes with a complaint of intermittent squint. Fundus is very difficult to view. What would, there is no pain at all. The child doesn't feel any pain. Okay, dilate, refer, dilate, refer, dilate, dilate, dilate. Okay, any more answer? Okay, great, dilate. Refer, dilate, refer. Okay, great. No one wants to wait and see, wait and observe. Okay, so the answer is refer immediately. Okay, again, here comes a challenge. You can't see the patient's baby's fundus at all, the master's fundus at all. So what you have to do, you have to immediately refer. Okay, it's very obvious that the baby has some obstruction. It can be some seeding in the vitreous, or it can be any tumor, or it can be even if it is very obvious, the corneal challenged corneal opacity or corneal ulcer, it will be very obvious. But there is no complaint of corneal opacity at all. So we should be aware and we should immediately refer them to the ophthalmologist. Okay, some case we may dilate, but in this case dilatation might lead to complication. Okay, because we are unsure whether the baby has any other condition. If the baby has that tumor grown large inside the fundus, it might have increased the intraocular pressure. When you dilate, what will happen? The iris root will go and block the anterior chamber, angle of anterior chamber, and the glaucoma will shoot up. The pressure will shoot up and the glaucoma might shoot up. Okay, so it is safe to refer the patient to the ophthalmologist. Okay, thank you so much. You guys are really interactive. Yeah, maybe cycloplegic refraction and fundus examination, we have answered that question. One question I want to ask all the optometrists in the world. Okay, why, when it comes to any primary observation or primary treatment or primary management or diagnosis, we are the face, right? We are the front liners, we are the face. Many people are not aware of this. Okay, even in the optometry profession circle, people think only optometrists can, sit in the optical or in a small clinic, do the refraction, and refer them to the hospital, give them, prescribe them with a spectacle. What do you think is the role of an optometrist? It's a very generic question. Whatever comes to your mind, you can, post or even unmute and talk. I just want to understand your perspective of being an optometrist. One word answer, one line answer, or even a paragraph, or you can even unmute and talk. Everything is welcome, but I want it to be interactive. I want to know what you people are thinking so that I can take it forward. Guys, are you guys with me? Great. I don't know who's this Lava, Mr. Lava phone. Do you want to, say something? No one wants to answer? Okay, but like we diagnose, measure, and management or refer for shared care. Okay, great. To do primary diagnosis of disease and disorders and correction, great. So exactly that means we are not okay. Optometrists can perform pre-op and post-op assessments and can detect systemic illness by observing the eye and can wow. If it is serious, wow, that's good. That's a good observation from optometry perspective. Great. I'm so happy that people are having very good understanding, about of their own profession, that is optometry. We would have heard a lot of talks behind us and questions to us, and thrown to us, asking why 4-year course and 5-year course. Just you're gonna sit in the optical and you're gonna sell the spectacle. What's the purpose of you learning all of these? But the fact is, we are not limited to sale spectacle. Am I correct? I haven't shared any presentation yet. I'll share soon, but I haven't shared anything for now. Okay, Mr. Wasim? Great. So, for your understanding and my understanding, I just want to be clear before I could start the session. Retinoblastoma, keep this in mind. We are the frontliner of ophthalmology. Okay, the entire ocular disease and eye care or vision care, everything comes to us first. So we should concentrate on ocular diseases as well, not just specialties. Ocular disease is also a specialty. Apart from low vision, binocular vision, contact lens, etc., ocular disease is one primary session we all need to master. Okay, that's when the optometry professionals will go to the higher and higher stage, and people will understand our power and our need to the society. Okay, having said that, I'll quickly share my screen. Can I request the host to please enable me to share the screen? Great, thanks. Okay, one more answer. An optometrist is a licensed healthcare professional who provides primary vision care, detect eye diseases, and manages non-surgical ocular conditions. Very well said. Okay, thank you so much. If at all, the meeting ends, please join using the same link again, guys. Thank you so much. Is the screen visible? Is the screen visible, guys? Now? I can't look at the chat box. You can either, say show thumbs up or great. Okay, thank you so much. Okay. Can you see what happened? What happened, Mr. Arman? You all of a sudden. Sorry, guys, some technical glitch here and there. Thank you so much. Okay. Hope you guys could see the screen again. Without any delay, I'll start the session. Can you see the image? I have, displayed one image of a child. Okay. Um, it shows two eyes. One eye has red reflex, the other eye has white reflex. Am I correct? Do we call it as white reflex? Yes. Okay. What do you think the child has? Why here red reflex and why here white reflex? Okay. So white reflex is not just for retinoblastoma. Okay, we do have several other conditions that shows white reflex. For example, congenital cataract. If you see in congenital cataract, white reflex will be there, and even in Coats disease, you can see white reflex. So white reflex is not a single diagnosis for retinoblastoma. I want you guys to understand this first, because whenever we talk about retinoblastoma, the immediate answer that comes to our mind would be white reflex. Okay, white reflex is one of the diagnosis, one of the signs for the diagnosis of retinoblastoma, not just a sign of retinoblastoma. Okay, having said that, can you look at this device? What device is it? What tool is it? Yes, I can see it. Red reflex shows normal grade. Yes, it's leukocoria. Retinal detachment or cataract grade. Indirect ophthalmoscopy, IDO, and lens grade. That's correct. That's very correct. This one, 20 diopter lens. Okay. This one, this image, the next image. A scan. A scan, A scan, B scan. No, there's no P scan. That's B scan, but this is not B scan. This is A scan. Correct. Amplitude scan. Correct. This is A scan. Great. And the last image, this one. Direct ophthalmoscope. Great. Which one do you think is useful to witness retinoblastoma? Which one? Which ophthalmoscope? Direct ophthalmoscope or indirect ophthalmoscope? Which one do we use for retinoblastoma? Direct ophthalmoscope, indirect ophthalmoscope, direct, indirect, both. Okay, great. I'm so happy, guys, that you are, very interactive. Thank you so much. You guys are correct. We use both the ophthalmoscope, like both A and B, that is direct and indirect. Okay, there is a difference. Direct ophthalmoscope you can use to witness only the red reflex and white reflex. Okay, just red and white reflex, the leukocoria part, you can witness using direct ophthalmoscope. If you want to see the size location, okay, and the spread of the tumor, you need indirect ophthalmoscope. Correct, exactly, Prabhu. First, we use direct ophthalmoscope, then we go for the indirect ophthalmoscope. Thank you so much, guys. Okay, start the session. Tumor. Today, what are we going to look at this? Tumor. Okay, we have two types of tumor. One is intraocular tumor. The other one is intraorbital tumor. Okay, intraocular tumor. Intraocular in the sense within the eye. Intraorbital is other than eye, it covers orbit part as well. Okay. In intraocular tumor, we can split it into two. One is for adults, the other one is for children. When it comes for adults, we say malignant melanoma. When it comes for children, okay, newborns, we call it as retinoblastoma. Same for the intraorbital, we have adult and children. For adults, we say cavernous hemangioma, and for children, rhabdomyosarcoma. Okay. Any tumor is classified into two. One is malignant, the other one is benign. Okay. Malignant means it is non-cancerous. Okay. It has no, much harm. It will not lead to death and all. So that is non-cancerous. It slows, it grows very slowly and it has definite border. Okay, if you look at it, it will have a definite border and there is no metastasis. Metastasis means multiplication of cells. Multiplication of cells, tumor cells. Okay, faster growth and moving from one location to the other location will not happen in this benign condition. Whereas in malignant, tumors are cancerous. Okay, it grows rapidly, very rapidly, and it will invade nearby tissues as well. Okay, if you say so, the closest location will also be get affected. The last one is it will spread throughout the body. It will not stick to one particular organ or location. If it starts in the eye, it will definitely, go to your brain or down to the liver. Okay, you can say anything when it comes to malignant. Now, let's move to retinoblastoma. Retinoblastoma is a vast topic. I'll try to cover as much as possible. Okay. So retinoblastoma, if you split, we can split the word retinoblastoma into three words. Okay. First is retino, which means retina. Okay. The light sensitive cell, the complex tissue we have in our eyes, the most complex tissue we have in our eyes, that is retina. And blast. Blast is a type of cell, okay? It's an immature cell or new cell which is not fully grown, okay? Which is not fully differentiated. Whenever, every time these blast cells will be differentiated into different layers and different tissues and different cells. Blast at this stage is very immature. And the last word is oma, O-M-A. Any word that ends with oma, it means tumor. It's a tumorous condition. Oma means tumor. Retinoblastoma, retina-related immature cells multiplying and leading to tumor. That's the simple explanation of retinoblastoma. These blast cell, this particular cell, are supposed to be glial cells. Okay, so retinoblastoma in short is a tumor that derives from the immature progenitor cells of retina. Okay, and this retinoblastoma is very specific to children. It's a pediatric cancer of the eyeball. And, we also call it as a primitive neuroectodermal tumor. Primitive neuroectodermal tumor. In short, we call it as peanut. Okay, just to, have this in mind, we call it as peanut. Okay. This tumor originates from a gene called RB gene. Okay. And you can diagnose this tumor at the age of 1.5 years. The maximum diagnosis happens at this stage of the child, and it will affect the baby who's less than 3 years old. Few condition, it has two types of retinoblastoma: the familial one and sporadic one. Familial one starts when the baby is in the womb as a fetus itself. Okay, the cancer stage would start at the stage of fetus itself. Okay. And in sporadic case, after baby's birth, the cancerous translation would start. Second, there is no gender preponderance. It can come to male child or female child. It can come to both boy and girl child. There is no female or male preponderance. And the third one is this is the first carcinoma. Retinoblastoma is the first carcinoma to be associated with some genetic abnormalities. Okay. Now let's move on to learn how this retinoblastoma occurs. Okay, as I said earlier, there is one gene called RB gene. This RB gene is responsible for the cause of retinoblastoma. This especially with the chromosome 13. Okay, this chromosome 13 RB1 gene is known as tumor suppressor gene. Um, Someone is hello, guys. Please do not make any changes in the screen. Kindly do not. Okay, I have written my notes. Please do not do any other changes. Okay. So here, this RB gene is responsible to suppress tumor. Okay. How it does is it will control the growth of these cells. It will control the multiplication of cells. Whenever this chromosome 13 gets affected, it will lead to rapid multiplication, rapid growth of cells, which leads to tumor. Okay. So the genetic cause can be this. First, you have a protein called E2F protein. Every RB gene, okay, RB gene, primitive RB gene will have a protein attached to it like a pocket. Okay, this is the RB gene and it has a pocket. This pocket has the protein called E2F protein. This protein is very, very important for the suppression of cells, growth of the cells. Currently, this chromosome 13 with the attachment of E2F, that is elongation factor to protein, is in the active hypophosphate stage. Okay, active hypophosphate stage. This is very, very important stage. Okay, if it is in this stage, the child is safe. What happens next is when it comes to tumor, at one point, this E2F protein will get separated from this chromosome 13 and RB gene, okay, which allows the RB gene to carry phosphates in its foreside. Only when it gets phosphates on its foresides, it can release the E2F factor protein. Okay, how this happens? This happens with the influence of cyclin D CDK4 process. Okay, it can happen because of three things. Whenever the cyclin D CDK4 interacts with this chromosome 13, it might misspell. Okay, instead of RB1 gene, it can be misspelled as R1B gene or B1R gene or RB1 gene. It can be misspelled as any of these, okay? Or the entire pair of gene can be lost, okay? Lost or erased. And the third one is incorporation of promoter methylation. Okay, these are the three reasons that leads to the freeness of E to F gene. Okay. When this E to F gene gets away from the RB gene, this becomes the activator. Okay, this becomes the activator and give rise to cyclin E. Okay, cyclin E has four phases. Can you see here? M, G1, S, and G2. Okay, G1S phase and G2M phase. We call it as G1S phase, this together, and G2M phase, these together. Okay, when this activator activates cyclin E and influences G1S phase and G2M phase, it will lead to proliferation. Proliferation is what? Multiplication of cells. Okay, growth of cells. This proliferation leads to the formation of retinoblastoma. And retinoblastoma is known as autosomal dominance in inheritance. Okay, why it is autosomal dominance in inheritance? Two things. First one is the mutation. Okay, the first mutation happens in heterozygous form and spreads to the whole body. Okay, this first mutation will happen in the entire body of a human, okay, of that particular child. Okay, it means when this proliferation takes place, when this activator activates E2F gene with G1S S and G2M phase, all the cyclin proliferation phase will happen throughout your body, in your entire body, in the first mutation. Okay, the second mutation is very, very important. The second mutation is called homozygous form mutation. This will occur only in retina. Okay, this will occur only in retina. That's why the baby gets retinoblastoma. When it comes to this whole body, not just retina, the liver and other different organs will also get spread of the tumor. Okay, if the second mutation occurs in the whole body. Since the second mutation occurs only in retina, the child gets retinoblastoma. Okay, we have two types of influences for retinoblastoma. One is familiar, the other one is special. As I said earlier, is hereditary. Hereditary, either one parent has this retinoblastoma already. They would have had when they were a kid. Would have had retinoblastoma, and that passes to the child. Okay, how it will pass? Like if the father, only one parent has retinoblastoma and the other one is absolutely normal, then the child they give birth would have in alternate form. Okay, the first child may or may not have retinoblastoma. The other child, the second child, will have the opposite. Example, retinoblastoma. Okay, this is hereditary, familial, and most of these cases will be bilateral. It will not be unilateral, it will be bilateral. Okay, and when it comes to sporadic, the baby would be normal at birth. As I said in the beginning of the session, in the familial phase, fetus stage itself, the mutation will start happening in the fetus stage itself. When it comes to sporadic, till birth, the baby will be normal. Okay, after the birth, the mutation occurs. The first mutation in this familial will happen in the fetus stage, but in sporadic stage, both the mutation, one first mutation and second mutation, that is, the mutation in the
Recording in progress.
Sorry guys, the frequently, some mishap is happening. It's okay if first team will just go ahead and do the session. It's okay. Okay, guys, sorry for the glitch again. So when it comes to sporadic, the mutation, both the mutation in the whole body and in the retina happens after the birth. That's why the baby, most of the unilateral cases are sporadic cases, which is not hereditary, not familial. Okay. Okay. As I said earlier, when the mutation happens in the whole body, okay, both the mutation 1 and 2 happens in the whole body, the body might lead to cause other, tumors and other cancerous conditions such as osteosarcoma that happens in the bone, pineoblastoma that occurs in the pineal gland, and sarcoma that happens in the soft tissues, and melanoma that occurs in the skin. Okay. Okay. Other than this, we have one more condition that is very, very important to notice when it comes to retinoblastoma, that is developmental delay. Okay, you must be seeing the child must have spoken at this month. Okay, it would have said the word mama or dada, the very first word at a particular stage, but it wouldn't have happened. It would have been delayed. The baby's first step to baby's, first speech to everything would have delayed, including growth. That developmental delay is due to deletion of 13q autosome chromosome in the particular chromosome. Okay, this chromosome 13 would have a missing piece. Okay, this missing piece, this deleted piece would cause the developmental delay. Can you see the difference? This chromosome, this pair of chromosome is different and this one is different. This is normal and the other one is totally different. The missing piece got deleted and the top piece and the bottom piece automatically got attached, and this leads to developmental delay. So as I said earlier, there are associated tumors like pineoblastoma and sarcoma and all melanoma. So this very specific one tumor that is associated is most of the condition would be pineoblastoma. Okay, pineoblastoma, it means the condition, the tumorous condition that occurs in the pineal gland. It is always associated with retinoblastoma. In Hindus mythology, they used to say Shivan, right? Shivan, he has three eyes. Okay, the third eye is known as pineal gland. In us, the third eye is known as pineal gland. That's why it has gotten a name called trilateral retinoblastoma. Okay, usually when a patient has one eye or one eye condition, we say unilateral. If it is in the both the eyes, we call it as bilateral. Since we consider this pineal gland as third eye, we are calling this retinoblastoma associated with pineoblastoma as trilateral retinoblastoma. It means the patient has bilateral retinoblastoma in both the eyes and pineoblastoma. Okay, that is one condition. And the second one is in association with secondary tumor. Okay, secondary tumor in the sense the retinoblastoma is the only condition it was there earlier. Okay, later due to some other influence. Okay, example CT scan. That's why in babies, especially if they suspect any tumor or cancer, they will not allow their baby for CT scan because CT scan radiation has the effect to influence other cells and cause cancer. Okay, so in some conditions, retinoblastoma during the treatment or diagnosis stage, it might accompany with secondary tumor, okay, post retinoblastoma, some secondary tumor, that is osteosarcoma. Example, in only in this stage you can see osteosarcoma and melanosarcoma or any other conditions. Okay, can you see melanoma, sarcoma? These are associated, secondary associated conditions. Now, let's move to stages. There are 4 stages when it comes to retinoblastoma. The first stage is called quiescent stage. Yes, anybody has any questions? Someone has raised their hands. Sorry for something. Any question? Anybody wants to ask me anything? If not, okay, great. I'll move on. So the first stage is called quiescent stage or quiet stage. Okay, the baby will not feel any pain here. The condition will become, so calm and quiet. Okay, please, Vaibhav, I request you not to, touch the screen. Okay. This is the first stage. You see leukocoria, okay? White in eye. White reflects in the eyes of the baby. It's called leukocoria. As I, said earlier, as we discussed earlier, leukocoria is not just a sign that sticks to retinoblastoma. We need to differential diagnosis. We need to do differential diagnosis. It can be congenital cataract, it can be retinoblastoma, it can be toxocariasis, it can be, retinopathy of prematurity or Coats disease. It can be any of these. So you need to be very, very careful because before giving any conclusion to your to the parent. Okay. Along with leukocoria, few children may accompany other ocular conditions like squint, the strabismus. And when it comes to strabismus, esophoria is very common. Okay, esophoria is a very common squint form in the retinoblastoma and secondary glaucoma and ophthalmos. As we discussed, when the tumor size increases inside the intraocular tumor, the vitreous will, be pushed forward and the intraocular pressure might increase. That increase in intraocular pressure would lead to secondary glaucoma. Of course, when the baby has secondary glaucoma, ophthalmos is common condition. And the third sign and easiest symptom, okay, third symptom, the easiest symptom, to understand this condition would be poor vision. Okay, when the baby has retinoblastoma, vision won't be clear and you can easily identify that. The next one is pseudo uveitis. Okay, whenever the seedings, retinoblastomas, that cancerous seedings floats in the vitreous or when it reaches to aqueous humor, you can easily witness this pseudo uveitis. And the last condition is nystagmus. Okay, what is nystagmus? The shaky of the eye. We call it as dancing eye. Okay, so nystagmus is also a condition. Whenever a baby comes with any of these conditions, please be aware. Okay, please be very sharp and clear to differential diagnose. Only if you see only squint, it doesn't mean the baby has only squint. You need to understand, identify the root cause of that particular condition. Understand the root cause of the glaucoma, identify the root cause of the uveitis. Only then you will get to know the right diagnosis. Right diagnosis means half the treatment and half the condition solved. Okay, so be clear, guys, in that. And I want to tell you something. There is a growth pattern. Okay, we have two types of growth pattern. One is endophytic, the other one is exophytic. Endo means what? Inside, within. Exo means outside. Okay, endo is inside and exo is outside. The growth of the tumor when it occurs from the retina into the vitreous towards the anterior side, okay, towards the anterior chamber. When the growth is towards the anterior chamber, it is endophytic growth, okay. Whenever the tumor that grows behind the retina, okay, towards the posterior side, okay, towards the brain, towards the crane, it means exophytic growth. It has exophytic growth. One of the reasons why you see white reflex is due to the cottage cheese appearance that occurs because of the endophytic growth of the tumor. Okay, when the tumor grows inside the eye, you might see this tumor as white reflex. Okay, sometimes this exophytic tumor, the growth outside the growth of the tumor might resemble ERD, that is exudative retinal detachment. Whatever it is, be it endophytic, be it exophytic, we gonna do A scan and B scan to confirm the diagnosis. Okay, along with that, we also do MRI scan as well. And other conditions, when the first mutation, due to the first mutation that happens in your whole body, you need to be aware of other conditions as well. Few might say the baby lost weight drastically. Okay, when the baby was born, they would say when the baby was born, it was 2.5 kg or 3 kg. By the time it is 6 months or 8 months, the baby would have lost half of its weight. Okay, drastic weight loss, and vomiting would be there, frequent vomiting. Baby cannot say that the patient, baby has headache, but it will cry constantly. Okay, that is actually headache. Okay, next, low blood count, hemoglobin count might go low, and the lumps under the skin. Okay, the visible lumps under the skin. Baby may have eye pain, eye redness, and bulging of the eye, like leading to ophthalmos. Or sometimes you see it as proptosis, but it is not actually proptosis. It is exophytic growth of the tumor. Okay, bleeding inside the eye, and at the end leading to blindness. So these are the other signs you need to have in mind when the baby comes. Okay, signs and symptoms. The first phase is over, and the second stage is called glaucomatous stage. Okay, this glaucomatous stage, as we discussed earlier, tumor cells, okay, the tumor seedings, we call it as vitreous seedings or aqueous seedlings. Okay, these might go and block the trabecular meshwork. Trabecular meshwork, as we all know, is like a mesh, like how you have sieve at home to filter tea or coffee. That trabecular meshwork is a sieve-like structure. When this trabecular meshwork gets blocked, it may lead to the increase of intraocular condition, causing glaucoma. And the second etiology can be compression of retinal veins. Okay, compression of retinal veins will affect the drainage of the blood. Okay, the flow of the blood, drainage of the blood, like from the eye to the heart. When it compresses, again, it might lead to glaucoma, increase in intraocular pressure, or damages the optic nerve and leads to glaucoma. And the third one is iris diaphragm. Okay, when the tumor grows in the vitreous would be pushed towards the anterior chamber. That push might lead to block the angle of anterior chamber with the iris root and lens diaphragm. Okay, again leading to the blockage of angle of anterior chamber, increases intraocular pressure, affects the optic nerve, and causes glaucoma. This is the second stage. And the third stage, very simple, the local spread. Okay, the spread will be within the eye, happens locally, and it leads to the extension towards the orbit. Okay, orbit can be behind the eyeball or in front of the eyeball. Okay, when it comes to orbit. The fourth one is distant metastasis stage. It has two. One is direct, the other one is through blood. When it travels through blood, it will affect liver for sure. Okay, but traveling through blood, the spread metastasis through blood is quite rare. If this metastasis through blood happens, definitely it will lead to death. Okay, the worst condition that may happen. When it is direct, when the metastasis is direct, it will pass on to, it will affect the optic nerve, and this optic nerve will lead to the brain, okay, direction of brain and affecting brain. Okay. Okay, the diagnosis. We saw so far we understood what is retinoblastoma, how it occurs, which chromosome and which gene is responsible, why that particular gene's influence causes retinoblastoma, and we saw signs and symptoms, and we saw 4 stages of retinoblastoma, and now we are moving to the diagnosis part. Okay, as we said, when you guys have answered so well in the first question, second question itself. As you rightly said, the first diagnosis is going to be with ophthalmoscopy, that is direct ophthalmoscopy. Okay, whenever the baby comes, the newborn baby as well, we do direct ophthalmoscopy to see red reflex and leukocoria. Okay, if there is red reflex, it means the baby is normal. When the baby has leukocoria, white reflex, the baby shows some abnormality and we need to check the baby. Okay. Second is B scan. B scan is, important to locate where the tumor is and to understand the size and the extent, the spread, okay, where it has spread. The third is A scan. Usually we do A, B scan together. We'll not do A scan separately and B scan separately because the spikes will, I'll help you to understand the, okay, the tumor's calcification and necrosis. Okay, we call it as VY pattern. Okay, V pattern will show you the hyperdense area. Hyperdense means what? Hyper means what? More. Okay, hyper dense area, and hypo means less, low dense area. You get hyper dense area when you see tumor calcification. Can you see this? Can you see the spike here? Wait, I'll use a different color. Okay, can you see the spike here? This is hyper dense. The A scan shows hyper arrows. Amplitude is very high, right? And at the same time, can you see the tumor here? Okay, this is tumor calcification. Okay, that's why the pattern is V hype. The next is hypodense area, which is necrosed area. Okay, ischemic necrosis would happen. Why ischemic necrosis is? Why the necrosis happens? Why particularly ischemic necrosis? The answer is very simple. For any tumor to grow, for any cell to grow, it needs blood supply, oxygen, correct? From where we do we get oxygen? From blood. Okay. When a tumor has to grow, the tumor multiplies rapidly and it has multiple cells, more number of cells. It means it needs more number of oxygen. It means it needs more number of blood supply. Okay, all the blood vessels will be sucked, all the bloods will be sucked for the growth of this tumor. Okay, leaving the close by tissues. Okay, when the blood is directly sucked by this tumor, the close by organs or tissues will not get blood supply. Okay, because all the blood supply is sucked by this tumor, leading to necrosis. Okay, now did you understand why necrosis comes in this retinoblastoma? So this is the reason. Okay, for any tumorous condition, ischemic necrosis is a very common sign that we see. Okay, the fourth is CT scan, but in most of the cases, we avoid CT scan, especially if the baby has familial retinoblastoma. Okay, as we said earlier, it will influence the cell and cause secondary tumor. Okay, secondary tumor. That's why we avoid CT scan in most of the cases. Unless it is unilateral and sporadic, we are not allowed to take CT scan. This is my, personal opinion, I would say. Okay, it's not in the book. I would say it's my personal opinion because I've seen it. So please do not go for CT scan immediately. MRI scan is a safer one. You need to take MRI scan to understand the optic nerve involvement. If the optic nerve involvement is more, then you have to be very careful. It's gonna affect your brain. Okay, so optic nerve involvement is very, very important. And the last one is plasma LDH activity. Plasma LDH activity is a very rare one. We don't usually do it, but in very rare condition, or if it is very important and necessary, then we have to go for it. Okay, this is not a diagnostic tool. I'm telling you, this is not a diagnostic tool. We used this for the prognostic value. Okay, to understand the prognosis value, we do plasma LDH activity. Otherwise, this is nowhere useful for diagnostics. Okay. The last part is treatment. If the tumor is less than 10 mm, the size of the tumor is less than 10 mm, then you can go for either of this. Okay. Tumor destructive therapy. We call it as tumor destructive therapy. You can use brachytherapy or cryotherapy or laser photocoagulation. Okay. We go to laser photocoagulation only when the tumor is less than or equal to 3 mm. Okay. When the tumor is very, very small, we go for laser photocoagulation. If the tumor is more than 3 mm, you can go for cryo. Okay, you go to cryo only when the spread is anterior to the equator in the intraocular level. Okay, anterior to the equator. Brachytherapy for any condition, you can go for brachytherapy. Any size within less than 10 mm, you can go for brachytherapy. Though it is intraocular or intraorbital, you can obviously you can go for this brachytherapy. The next one is greater than 10 mm, which is larger in size. You don't have any other option except to enucleate. Okay, you have to remove the whole eyeball to avoid the spread, to prevent the spread of retinoblastoma cell to the other or neighboring structures. Okay, when you do this enucleation, please remember to remove optic nerve to some extent, because we need to send this to histopathological evaluation, HPE. Why? Because you need to understand the spread of this optic nerve to prevent other organs, to get from other, tumors like sarcoma and all. To avoid that, you need to be very, very active and proactive to enucleate optic nerve to some extent and send it to histopathological evaluation. When it comes to histopathological evaluation, this is the image that usually we get. Okay, we call it as rosette, sign. This rosette, it looks like a flower, right? A rosette design. We have two different rosettes. One is Flexner, Wintersteiner rosette. The other one is Homerite rosette. Okay, if you see this pattern, can you see? You have a large difference between these two patterns, because this one has this Flexner, has a vacuole. Okay, this vacuole is filled with glial cells. Okay, the other one, Homerite rosette, will not have that vacuole, and this is very fleshy. Can you see the difference? It is so bright and it is so much like dendrons. Okay, it is very obvious which is Flexner Wintersteiner and which is Homerite rosette. So have this understanding. Okay, anyway, you're not going to do the histopathology, but For the understanding the theory part, I'm just explaining you how the HPE works. Okay, if you see any sign or some remuneration of this rosette condition, flexner in a rosette, definitely you'll have to be careful and ask the patient to do the entire body scan, and every tissue, the closest tissue has to be checked and tested for the presence of this condition, any tumor condition. Okay. And the last treatment would be chemotherapy, where we go for EEC regimen, vincristine, etoposide, and carboplatin. And at last, though you do anything, everything, the combination, please ask the patient to come once in a while and do the testing. Okay, it is, there is a proverb, right? Prevention is better than cure. So, it is very easy if the patient comes early. Okay, if we diagnose early, we can save their life and save the vision as well. So, keep this in mind. That's the end of the session. Okay. Guys, do you have like any doubt, or do you want me to repeat anything? Any questions for me? You can unmute and ask. Even if you want to put it in the chat box, it's most welcome. So what is the prognosis in early intervention? Are there specific visual acuity values we can expect? As I said earlier, you can't expect the baby to, say the visual acuity value since they're babies. We do have other, to test visual acuity, we do have other, processes. We do that, and since the baby, if the baby comes within 1 year or 1.5 years, of course the fixation won't be there and the baby will not be responding to light. Even if you shine bright light straight into the eye, the baby will not show like much reaction or much excitement, or immediate closing of eyes or squinting of eyes will not happen. So that is where you should understand that the baby's visual acuity has gone down and it is very very poor. Okay, that is one. How squint related to RB? Okay. How the squint happens is, very simple. I'll tell you with a quick example. If the how Okay, what happens in eye? The light passes into the eyeball through the cornea, passes through the vitreous and falls on the retina. Correct? When this happens, when this is normal, the baby's eyes will be straight, correct, aligned. Unless it has any other physiological condition like loosening or tightening of extraocular muscle and any other condition, the squint will not obviously happen. In this case, this is due to a pathology. If the baby or the child has even congenital cataract, the obstruction of light is there. When the light is not passed on to the retina, the brain will think that this eye is useless. Okay, that leads to the it will cut, the brain will cut the supply to your eyeball, the blood supply, or slowly it will start cutting the signal and blood supply to the eyeball, which leads to the resting position of the eyeball. The resting position here would be ESO, okay, towards the nasal side. The resting position, we see it as strabismus or squint. Okay, this is a like basic thing how I can explain, how this RB is related to squint, is related to RB. Okay, when the obstruction is there, when the light is not passing, the brain will automatically detect the organ as useless. Okay, when the brain thinks I this particular left eye or right eye as useless, it will not send signal or even blood supply to your eyeball. In the later stage, it might lead to like losing your eyeball as well. Okay, it will lead to the resting position that we call it as squint. Strabismus that causes squint. Thank you so much. Where is it? Okay, thank you so much, Divedi. Thank you, Sundara Divedi. Any other questions or doubts, guys? I'm open for the question. We'll have like 2 more minutes. Yeah. Any current interventions for RB or SERS? Of course, we have a lot of interventions. Um, I know one study is currently happening. I'm sorry, I cannot reveal their name due to confidentiality problem. One hospital, like one, well-versed clinic is doing a massive project. A study in one whole district of Tamil Nadu. Okay, they are doing research. They are doing insisting parents and even general doctors and gynecologists to refer the baby to the optometric care and ophthalmology care. And they are doing so much study. Many things are about to open up, and I'm looking forward for it. Since the study is ongoing and it has to be very confidential, so I cannot reveal the name. You might ask me how I got to know. That is one of my mentor is doing. So that's how I got to know the thing. And we have a lot of papers as well. If you're in touch with any of the hosts, I can of course share those papers, research papers. You can read it when you have time. I like to explain the squint in term in which eye tries to see by accommodating, which in turn leads to esotropia. I think so. I mean, you're asking me to explain how this esotropia happens or how it is relevant to RB. It's a general question. Can you just, help me to understand the question? It will be great, Mr. Suntaravadivelu. Should we examine? Till then, I'll move to the next question. If you can explain me, much better, I can definitely understand and answer your question. Should we need to examine the posterior segment before squint exam? Of course, any squint exam. If I'm not saying all squints are relevant to retinoblastoma. When you see a child, when you see a child within a newborn 2 3 year old and with a white reflex, okay. Whenever a baby comes, we'll definitely do ophthalmoscopy. When you do the ophthalmoscopy, you will be seeing the white reflex in terms of retinoblastoma or any other relevant ocular condition when that comes under DD. If you see white reflex, please go and do posterior segment examination. That is what we would suggest. Okay, as an optometrist and even ophthalmologist would suggest you to do posterior segment evaluation whenever the baby comes. Along with the squint, it is good to do posterior segment evaluation, because if there's any obstruction also, if the baby has vitreous opacity also, it might lead to squint. Okay, if the baby has severe cataract also, the baby can show the sign of squint. So it is good to do posterior segment evaluation. It is not only limited to RB. You can do it to understand the root cause and help the diagnosis and start the management planning. Thank you so much, Mr. Sithold. Thank you, Ahmed. I'm so happy that you guys are enjoying the session and enjoy the session. Thank you so much. In relation to how the media is not just, so light can't reach the retina, so the brain forces the eye to see something in terms of accommodation. So the eye turns inwards. That's what I try to explain. Great. So that is one of the thing, as that is correct. Actually, what you said, Sundara Vadivel, is correct. Okay, that is also one thing that happens when your eye is dry. But in terms of accommodation, it will when you see something, at closer distance, your lens will try to accommodate. Otherwise, when you look at distance, okay, when you look at some other distance other than this 1 arm distance of 40 centimeter, your eyes will not accommodate. Okay, accommodation will happen only when you look at the closer distance. So in esotropia, most like other binocular condition, you can say accommodation is one of the reasons. But in RD, accommodation will not be a major reason. The major reason would be due to the obstruction, due to the inhibition of light, and leading to the signal, less signal receiving from the brain, and the brain moves the eyes to the resting phase. Thank you so much, guys. I'm so happy that you all like this session. Thank you so much, host, if all the questions are done, and I'm also done. Thank you so much. And you guys were very, very interactive, and I liked it. Thank you so much.